Hello, everybody. You're very welcome to the webinar. My name is Fergal O'Keefe, and this is the MS Ireland webinar series, The Unspeakable Bits. I'm delighted to say that our host tonight, as usual, is Trevor Gleeson, and we have a wonderful panel of guests, including Dr. Orla Tuohy, Professor James Bowen, and Ciara O'Mara. So just to let people know that there's a Q&A button at the bottom there, so if you please use that with questions, and Travis will then, throughout the evening, try his best to get to as many questions as possible. And also, just to let you know that we have another webinar coming up this month for World MS Day, which is the 30th of May, and we're having it on the evening of the 29th of May, talking about people's diagnosis stories. So I will actually put a link up in the chat or in the Q&A about that for everybody to see. So without further ado, I'll hand over now to Travis.
Fergal, thank you very much, and hello to everyone. You're welcome back. This is our final Unspeakable Bits before we take a break for the summer, and I hope that wherever you are, it is as lovely as it has been in West Kerry for the past couple of weeks. Now, that being said, it's been very warm today, and I've had a little bit of MS progression over the last week, so words aren't my friends tonight, so that's not what you want to hear from someone hosting a program like this, but look, we all know what MS is. But we will get you out of here in time to watch Emmy and the Eurovision quarterfinals or semifinals tonight. Don't you worry. I'm Travis Gleeson, your host, as Fergal said, and this is our third series in the Unspeakable Bits. And along with you, our viewers, there are a fair good few people to thank, and I'd like to mention them now. We thank MS Ireland for affording us this platform to delve into the topics. It's not so easy to talk about some of the subject matter, even among family and friends who know us and know about MS. Many of our topics and subjects were once taboo in many places, and maybe not just here in Ireland, and maybe still a little bit. Having time and space to talk about things that aren't comfortable hearing, let alone discussing, it's an important resource for those of us living with MS and co-occurring conditions. So Gomarina Mahagwith to MS Ireland. And it's also impossible to put these programs on without our expert panelists. We've had leaders in their fields from around the globe with us as we jump into the unspeakable deep end, and we thank them, one and all, and it's been invaluable, their help with episodes past, present, and future. Speaking of which, all of our previous episodes of the Unspeakable Bits webcast are available on the MS Ireland YouTube channel for your viewing. This program will be up in 24, 48 hours, depending on what Fergal feels like. And before we wrap, I'll have Fergal put up a link to those previous programs so that you can see them. And we invite your questions that you can submit to our panel tonight. As Fergal mentioned, put them in the questions tab. Do not use the chat function because that just mucks up the whole system. And our whole system is pretty much mucked up because of MS anyway. So, as I mentioned, our expert panelists tonight, I think we have a bit of a West Coast vibe going on. Though she practices neurology as a consultant at Waterford University Hospital in Ireland's East Coast, Dr. Orla Tuohy is joining us live from the Irish Neurological Association's meeting in Tralee here in County Kerry. So first, Dr. Tuohy, welcome to the West, and thank you for taking the time to chat with us tonight. I believe you're even missing pre-dinner social hour to be here, so I think we might owe you a cocktail next time we see you. So welcome.
Thanks for having me.
Further up the coast is nurse lecturer Ciara O'Meara from the School of Nursing and Midwifery at NUIG in Galway, a Cork woman living in Galway. You can take the woman out of Munster, but you can't take Munster out of the woman. Am I wrong, Ciara?
No, you're right, Travis.
Who are you shouting for while you're up there, by the way?
Oh, but see, Travis, I'm actually from Tip. Just to throw another spanner
Oh,
in. I
jeez.
trained in Cork, but I'm from Tip, so be very, very careful. You're on dodgy.
All right, well, we'll talk hurling then.
Yeah.
Very good. Also from the West Coast, but not the Irish one, recently retired medical director of the MS Center at Swedish Neuroscience Institute, Professor James Bowen, joins us from Seattle, Washington, USA. And Jim, it looks like retirement's treating you quite well.
Yes, it's been a huge change, but at least I still have a toe in the MS world with things like this. So thanks for inviting me.
Well, I think we might just be grabbing your ankle in the next few days as well. So Listen, it's a little bit off topic, Dr. Tuohy, but it would be irresponsible of me not to ask if there, I know it was the first day of the meetings there. Is there any interesting news that you might have heard during your attendance or in your chats in between conference meetings today?
Yeah, so I suppose there were a couple of MS talks, and Dr. Lisa Costello, who's a neurologist in Beaumont, gave an update on sort of the latest kind of hot topics in terms of research in clinical MS as well. So one of those is that the McDonald criteria that are used to diagnose MS are going to be updated to hopefully, I suppose, make it the process of diagnosing MS more straightforward and also more accurate, so that people are getting diagnosed correctly and hopefully in a more timely fashion. And then there was the other topic she reviewed was a new class of drugs that, again, hopefully will make it into the market for use in MS called BTK inhibitors. And these act in a different way to a lot of the other disease modifying therapies that we have. And there have been some encouraging results that have come out of the trials showing that they seem to have a beneficial effect on preventing worsening of MS in patients with secondary progressive MS. So that's quite promising because that's an area in MS where we've sort of always been lacking in therapies, and that's sort of been the poor relation in terms of having drugs that target that progressive aspect of MS.
And what
Um,
stage in the trials are those meds right now? Phase
so
two?
that one, the BTK inhibitor called tolebrutinib, has just been published. The phase 3 studies have
Okay,
been published in that. So, that's often the last step to kind of getting approved and getting licensed for use.
very good.
Um, yeah, there was also then, I suppose, on some of the other presentations, some of the teams from around Ireland, as was Dr. Audrey Reynolds from St. Vincent's presented some research that they've been doing with trying to incorporate sort of measurements that we can use in the clinic for detecting changes in people again with progressive MS to see can we have more sensitive outcome measures that they looked in particular at sort of balance measurements and speech measurements, and whether we could use these in the clinic and also potentially in clinical trials as an outcome measure. I suppose one of the things that counts against us a lot when we're trying to see if drugs have an effect in progressive MS is that the measurement tools that are used. So a lot of people will have heard of that EDSS scale. So it's a relatively crude measure, and a lot of it is based on walking. So it might be hard, for example, if you're trialing a drug that might improve things like your upper limb function, or that might improve things like cognition, when what you're just measuring is people's sort of walking ability, to see if if some of these drugs have an effect on those components of MS, which are, equally as important as sort of walking as well. So that's kind of encouraging to see that sort of work being done and that research being done in Ireland as well.
No, that's really important stuff because obviously, how can we know if we've got there if we don't know where there is? And I think it was Professor Giovannoni who coined the phrase that for people with progressive MS, their arms are their legs. So that's upper body stuff. That's really important. A couple of questions because not only are we an Irish audience, and there are a couple of hundred people who will be online with us now. But by the time this kind of settles in on the interweb, it'll be nearly 1,000 people who watch it. So not just Ireland and the UK and the US, but all over the globe. So maybe just to give people a sense of what the Irish neurology scene looks like, approximately how many practicing neurologists are there in Ireland now? And Jim, don't you laugh because I'm going to tell the story before about me moving here. So, Dr.
Yeah.
Tuohy?
And gosh, you put me on the spot. I don't know if I have an accurate number. I would say approximately 50, and I might be a bit off the mark there. But yeah, it is increasing all the time. For example, the centre where I worked, there's now four of us, whereas previously there would have been 1.5 or that. So the consultant numbers are increasing, which
No,
is
that's very
is
good. And that's
positive.
that's
Yeah.
partially because MS Ireland and the Neurological Alliance have really pushed
Yeah.
the government to and the HSE to
Yeah.
increase that number. So that's great. For you personally in your clinic, what's the approximate waiting time for we'll say a new patient to come and see you?
Yeah, so I do a weekly MS clinic, and we have, I suppose, 2 new patient slots per week in that clinic. The rest are sort of follow-up patients who come back to see us. Um, so for those 2 new patient slots, I suppose they're people who might already have been diagnosed with MS by one of my colleagues, and so might be attending a general clinic, and might be coming to our clinic just to discuss treatments, for example. So I would say, on average, we would aim to see people within 3 months of referral. But again, I know people can be waiting much longer for that initial appointment with the neurologist, particularly when they're on this very long outpatient waiting list, along with patients with potentially lots of other neurological conditions as well. So that's often where that delay, comes in.
Right, and I understand that here in Ireland, it's I don't want to use the word general neurology because that makes it sound less than it is, because you have to be specialized in so many places. But you would be seeing a lot of patients with different neurological conditions, from stroke to Alzheimer's to Parkinson's to et cetera, correct?
Yeah, so that's correct. So I suppose most people would, the bulk of their workload would be that general neurology, where it's sort of unselected. And then so increasingly neurologists then would have a subspecialty, be that Parkinson's or epilepsy or MS, where they would do that specialist clinic. And I think that, that's a good thing. I see that as a positive thing, because I suppose you can then make sure that you're up to date with all the latest, research and guidelines, and then hopefully build up a team as well, with a specialist nursing team working alongside you as well, and sort of develop I suppose, an MS clinic where you have, the appropriate allied health professionals working alongside you, so patients get I suppose, good value out of coming to clinic and know that there's a team of people looking after them.
And that's a perfect segue into the team. Ciara being a nurse, let's get back to the topic at hand. The ins and outs of needing to find a new neurologist when we have to. We know that there are a number of reasons someone might need to find a new doctor. We might move house, perhaps not in Ireland, but other parts of the world. Insurance cover might cause one to go looking for a new neurologist. There are those newly diagnosed and searching out their first provider, and of course, there are times that we just don't fit well with our medical team, and that happens. It's not a big deal; it just happens. So, Ciara, I'll start with you. You moved a few hours away from Cork not that long ago for a new job. Tell us about that experience in finding a new neurologist, or did you? Do you just commute back?
No, Travis. So actually, because, and I suppose it's fallen into HSE and catchment areas and where people live. So I'm, and this is my story all across the country. I'm Tipperary trained in Cork, but when I was first diagnosed, it was diagnosed in Ballinasloe in Galway, and I was referred then to the University Hospital in Galway. So I got kind of my first symptoms and that first indication of a diagnosis when I was at home in Tip. So it was, let's go, Ballinasloe was our nearest hospital, and then from there referred into the University Hospital in Galway. So even when I lived in Cork and I was nursing down there, I kept my care in Galway, I suppose, for 2 reasons. One, I was a newly qualified nurse. The diagnosis was new. So, and I was in the hospital scene. I didn't want other people to know. I didn't want to meet my neurologist on the corridor. I didn't want to meet the nurse specialist at that time until I got my head around it. So that was one of the reasons. And then the other reason was I didn't know if Cork was where I was going to stay, which inevitably it wasn't. So it was, look, let's have it in Galway and see what happens from there. And actually, I suppose where life has taken me, I haven't had to move neurologist. As of yet, as of the moment, I have the same neurologist that I've had since I've been diagnosed.
And so tell me, for those who aren't really sure, and we won't get the RSA involved here to tell about how heavy your foot is, but about how long a commute was that from Cork up to Ballinasloe to see your neurologist?
Yeah, so it was 2.5 hours, Travis, maybe three, depending on the time of day that you were going and traffic and everything like that. So you're definitely looking 2.5 hours more door to door.
And how long have you been diagnosed and seeing
Oh,
your
I've been
neurologist there?
15 years this June. Yeah.
So you were diagnosed when you were 8 or 9 years old, is it?
Thanks, Travis.
Uh,
No, I was in, without giving my age away, my early 20s.
your early 20s, right?
Yeah.
I suppose one of the reasons that MS Ireland asks me to host this, actually, quite frankly, I seldom can understand why, but It's because I live with MS as well and have that experience. As a bit of disclosure, Dr. Bowen, and the reason that I probably slipped in a Jim here and there, Dr. Bowen is, or Professor Bowen, as we would say here, is formerly was my specialist, my neurologist. When I was diagnosed by a general neurologist about an hour and a half north of Seattle, because that's where I lived, and that general neurologist said there's only one person that you should see, and he had done a fellowship with Professor Bowen before. So that's how we met. And the story that I was going to allude to there was when I first came over here to Ireland for a 3-month winter. Professor Bowen said, Travis, there are two words that don't go together in my head, and that's Ireland and neurologist. And at the time, and this was what, 2004, 2005, something like that, I was on a first name basis with more MS specializing neurologists in the Seattle area and the Pacific Northwest than Ireland had, general neurologists. So things in the last 25 years have certainly changed a lot. And of course, now I'm settling in with my Irish neurologist, but I do have to tell the story of when I first went into my GP here in West Kerry. We were starting to have a chat and talking about MS and this and that, and a paper that I had just co-authored that was in the Lancet, or an article, and that there was a new subject coming out that I was, that was coming in the New England Journal of Medicine that I was listed as an author on. And he stopped me right there and he said, Travis, I have to tell you, you know more about multiple sclerosis than I did. And now, and fair enough, he's a country GP and he's got a lot of patients about a lot of things, and I'm a bit of a professional patient. But that was a little bit of a coming up short, that when your doctor tells you that you know more about the subject than he does. But that's not my neurologist, that's for certain. As we move on now here, please don't hesitate to send in your questions. I see that we've got a couple of them coming right now. So please keep those coming through. Professor Bowen, I think I followed you to 2, maybe 3 MS centers in the Northwest. And as I said earlier, you've recently retired from your practice. Someone wants to know what you're doing with your free time. It's our old friend in Hawaii, quite frankly. So we are global here. So would you help our guests understand from the medical professional's perspective, tell us about when your patients have to move on or decide to move on.
Well, the United States has a unique healthcare system. And
all of us in Ireland and Europe are laughing right now with the term.
That's right.
Unique.
System in air quotes. And heavily driven by the insurance industry. So by far the most common reason that a person would switch clinics or switch doctors is because the insurance will not cover their previous one. So we are constantly having to deal with that. And other than insurance, also the U.S. population is probably more mobile than a lot of other places in the world, and people are moving out of state for their jobs and families. So we do have a fair amount of turnover like that. Similar to other places in the world, there's a shortage of neurologists in general and MS specialists in particular. And here in the Pacific Northwest, Seattle is the main medical hub for the states of Washington, Alaska, Idaho, and Montana. And for those who don't have the travel perspective, it's a 3.5-hour flight to Anchorage in Alaska. And then that's assuming that you get to Anchorage. One of my patients in the winter had to take a dog sled for several hours to get to a small airplane to fly to Anchorage and then here. So we do have a lot of very rural areas, and that also impacts access to healthcare, and especially healthcare in particular.
And a 3-hour flight to Anchorage. I remember one time being up and doing a presentation for the MS Society in Juneau, and I think 3/4 of the people that were in the room that I was talking to that day were actually your parents or your patients, and I just couldn't believe that someone would get on a plane and fly that far. But then I met people in Missoula, Montana that were doing the same exact thing. So that is a big catchment area indeed. Dr. Tuohy, Ireland isn't that big a place, certainly. And our population of people living with MS is about the same as the general three-county area around the Puget Sound, around Seattle. So how far do some of your patients travel to see you in your clinic?
So we'd have patients who would come from, I suppose, Carlow, Tipperary, Wexford as well. And I suppose, you know, 2 hours might be kind of towards the longer, distance that people would travel. Um,
That's still a long time, particularly if you're thinking about it's 2 hours there, it's 2 hours back.
and
It's
waiting around time as well, yeah. And yeah,
yeah,
so it can be
and
exhausting.
the actual clinic time, and then the waiting room time, and then you've got to grab a cup of tea or something on the way there, on the way back, and it's a day plus, really. And then there's the recovery time, there's all that. So it is difficult, but I suppose a 2.5 hour drive is better than a dog sled ride and then a 3 hour plane ride and then Seattle traffic to come and to see your team. Um, I let's see, we've got a few other questions coming in here. No, those are well, Sharon Dodge. Sharon just mentioned that she flies 6 hours to see her neurologist and then flies 6 hours home. I'm suspecting that's not the same day, Sharon. Listen, I have a vivid memory of my first speaking assignment for the local chapter of the National MS Society. This was in Seattle. I was closing a panel discussion that included, I think it was about 8 neurologists, MS specialists, not all neurologists, who practice at different centers in the area. And first, I hadn't learned the Irish phrase, but I didn't realize we were spoilt for choice. But surely we were if we had that many specialists just in the Seattle area. And second, as I listened to the different neurologists answering questions from the audience, I realized that one, I could see why every single person would choose one of those different doctors. There was definitely a fit there for every type of personality. And two, I realized that I had the right guy in Professor Bowen. It's different strokes for different folks. Ciara, I know that those kinds of meetings where you can see the panel of all the people that's available to you are rare, but how can a person with MS in Ireland find out about their choices when it comes to finding or switching neurologists or GPs, or is it that even possible in your estimation?
Yeah, it is, Travis. I think it's that mentality of sometimes we think, oh, this is the doctor or the consultant we've been given, and we're not going to upset the apple cart, and we might not get on with them and have that relationship, but we'll just stay and do it because we don't want to upset our treatment or upset our progress. There's that kind of mentality sometimes, but people are fully entitled to, look for another neurologist. I know it's sometimes not easy because there may be areas where there is only 2 or 3 neurologists, maybe only one in a certain area, and you're factoring in then patient caseloads and, time then to maybe see a new neurologist. And there is that scope. We're very fortunate that a lot of areas do have MS nurse specialists and advanced nurse practitioners. And I know for myself, that's who I deal with most. And there is that scope to kind of say to them, or, if you didn't have that relationship that you wanted, that there is scope to maybe have a different MS nurse to come to you. And sometimes I think we don't realize that we can do it. There is a process to it, and it's not as easy as you'll see this consultant today and another one next month, because there is that caseload and turnovers and everything. But I think it's really important, especially for a patient, if like we look at self-management of your condition and being an advocate for your own condition, and that's very difficult if you don't have those healthcare relationships, because it has to be a shared decision-making journey, and if you don't have that with your neurologist, that's going to impact on your care, you know.
Yeah, and I definitely want to get with you on MS nurses and their part in the team, and particularly when things are difficult in a bit. But when I was researching this topic, I found a video that was from the UK talking almost specifically about this, and their guest was a person with MS who happened to work for the NHS, their equivalent, I suppose, of the HSE. And for them, the concept was the first stop, if you feel like you need to change, or you want a second opinion, or you want another referral, etc., was to go back to your GP and have that conversation, because in general they're the gatekeepers and would make that, send that letter. They do that all the time. Dr. Tuohy, is that how a referral would work here? And well, first off, let's get to some definitions. There's a difference between a referral and a second opinion. Can you maybe help us with that language, just so that everyone is sure of what we're talking about, and then we can get into that?
Yeah, so I suppose the referral would be maybe that initial contact that would be made maybe when your GP or maybe another physician within the hospital would refer a patient to a neurologist for that first consultation. A second opinion then might be, for example, you have someone with multiple sclerosis, example, who is trying to decide on a treatment, and you might want a second opinion on what treatment is best because there isn't one front runner, for example. Or you might want a second opinion just if the person with MS doesn't have maybe the typical symptoms, or if it's not 100% clear from the tests as to whether the diagnosis is accurate, then you might ask for a second opinion from a second neurologist.
Okay, so that's the difference there. And that's you asking for a second opinion on a judgment call of you. But how often, or how would then a patient say, I'm not so sure about that. How can I get a second opinion? Would they ask their practicing neurologist to go back to the GP for that?
Yeah, so they could do either route. I suppose you'd hope that they'd be comfortable enough to ask you, or to maybe, to ask the MS nurse as well, I suppose would be the other route, or the GP if they maybe didn't want to have that conversation with you. But either route should be available to them.
So there's still that fear of the patriarchy, matriarchy sort of concept in the hierarchy, we'll call it, in the Irish medical system, that people don't want to upset the apple cart. We'll talk a lot, but we won't say anything.
Yeah, and I suppose that's, it's an Irish thing maybe to not complain about things and to just put up with things. And I suppose maybe Ciara would have an insight as well as to, sometimes you don't feel you can kind of say that in front of your neurologist maybe, which shouldn't be the case. If someone, is not comfortable with, for example, the treatment that you've recommended, they start on, and they want to just get another opinion, I think they should be entitled to that, and it should be available to them.
And you mentioned that you're in a clinic that has 3 neurologists now. Do all of them have their skills at MS are sharp enough that you would feel comfortable switching around?
Absolutely, yeah. And I suppose one of the advantages that we have nowadays as well is that a lot of, for example, if there's, a difficult treatment decision to be made, that there are forums now to have, multidisciplinary meetings as well, where you can discuss kind of challenging cases, or cases, for example, where someone might want a second treatment opinion. So sometimes you can get that in a different forum as well. And then you can kind of then, feedback then to the patient that, look, we've discussed your case, and this was what the recommendation was, and just, see if that maybe allays the fears that they might have about a particular treatment not being suitable, for example.
And I suppose one of the things that, as a patient, as a person living with a disease, if something isn't happening fast enough, or we're not getting better, that's not necessarily, a bad doc or the wrong doc. It's a bad disease that we have. We can't really blame progress or progression of the disease on our medical team so much. Everyone's working to try to end this disease and to make things as good as possible. Professor Bowen, you were the medical director of a fairly large clinic there in the Pacific Northwest of America. But by the time that you decided to, hang it up, how many MS specialists, because I know you had physiatrists as well, were there in your clinic?
Yeah, we have 4 MS specialists, and they all exclusively do MS. So no, nothing else. We're part of a group of about 65 neurologists, but 4 of them that specialize in MS. And then we did have, or we still do have, the physiatrist and other ancillary services associated with it.
And was it then fairly common to after maybe the first few meetings, etc., to that someone wanted to, this isn't working, let's go with someone else? Was that did that fall on you as the director, or was that the nurse practitioner Bobby's job to help steer people around? We know who had the rudder in her hand.
That's right. Yeah, it's Bobby, who is our outstanding MS nurse practitioner, would frequently steer people. But it's not that uncommon for patients to seek a second opinion. They just want to see if their opinion they've got is on track and compare it to other people. And the patients are often reluctant to directly bring that up with the doctor because they think we will be offended that they want a second opinion from someone else. But I have a kind of a pat phrase that I fire right back at them, that if your doctor has a problem with a second opinion, you're seeing the wrong doctor. Because why should you be offended by that? So we're quite supportive of people getting second opinions, and even outside our system. And in fact, in many ways, I would almost prefer that if they get a second opinion, they do it from another MS center in our region, because if you the four neurologists that we have, we practice together for so long that we pretty much have the same opinion. So if you want a different opinion, you probably need to get outside our system to get that.
Mm-hmm. And I think that that's probably one of the most important things for our listeners to hear, is that your doctors have thick skin and they want the best for you. It's not always going to be easy to do, particularly here in Ireland. Dr. Tuohy, you were saying, obviously this isn't going to be something that you have your appointment and 2 or 3 or 4 weeks later you're going to get that second opinion. It is going to take some time, and things are going to be different. But what I'm hearing, and I hope that our listeners are hearing, and our viewers, is that it's not a big deal. Now, you can't go hopping around the country, and every time something doesn't come up, you don't try to fix it. You just jump ship. That doesn't work. But what I'm hearing is that you want the best for your patients, and even if that's not you and your team, you want the best. Is that correct, Doctor?
Yeah, absolutely. Yeah, and I think James put it very well there as well. If if a doctor's offended that you ask a second opinion, then maybe they're the one with the problem, I suppose, isn't it? But absolutely, yeah. I mean, these are big decisions that people are making, particularly when it comes to deciding and committing to a treatment and things like that. And if they're not comfortable with that, and it is such a big decision, that I think if a second opinion, and maybe it might, have the same kind of outcome, but I think at least it would, allay their fears and reassure them. So I think, yeah. I mean, yeah, the one disadvantage is that there might be that wait time for a second opinion, and maybe you might be concerned about someone having to wait and, for example, delaying treatment and things. But yeah, I'm
And
all
so,
for
going back to that sort of that Irish sensibility and the conversation, etc., maybe you can, sometimes the stars don't align. So maybe there is time for a change. From the professional perspective, how do we open that conversation with you? I mean, how do we say, we're going to have to stop now, and we need to find a different way to do this? How do we open that conversation as patients?
Yeah, and I suppose part of it is on, how the consultation is structured as well. So I suppose it depends if someone, it's their first time meeting, or if they're a follow-up patient. And I suppose the first time you meet someone, you want to go through their MS history and get a feel for their MS, and set out a management plan. And I suppose there should be time for discussion at the end then as well, for you then to communicate the plan and to get the feedback as to what that person thinks of your plan, and what parts that they that they have further questions about, or that they maybe have concerns about, and to see, can you, between you, kind of resolve those. I think, going back, kind of your MS nurse is so valuable at it as well, because there are maybe things that people might be more comfortable with broaching with the MS nurse, who hopefully will be in the room next door, and that maybe you'll get the feedback that way then as well. So
And is having a conversation with the GP, who you might be more comfortable with, or see just as often. Sometimes I know in the US, a lot of MS patients see their their MS specialists more than they actually see their primary care providers, as they're called in America. Um, so yeah,
Yeah, you
that's
might have that that good relationship that's been built up over the years with your GP as well. So definitely that's the other person who might be your protocol.
pass them a note and ask them to pass that on to the. It sounds very parochial, doesn't it? Professor, as we said, you've had your share of patients who need to move on for one reason or another. And when it's time to find somebody new from your point of view, not from the patient's, I mean, I suppose, have you ever been the one that said, actually, I think maybe, and how's that? How does that work? It's, I don't think we should see each other anymore.
Yeah. Well, it's rare, but we do have patients that just aren't a good personality fit. And if we're having a lot of conflict with the patient and we just can't resolve that conflict on a personality basis, then uh, that may be a good reason to change. And oftentimes you can just bring it up to the patient to just be straightforward about it and say that this does not seem to be working. We're not communicating well, and usually the patient senses the same thing and will jump in, and then you can agree to, well, there might be this other provider. I actually, if patients are seeking a second opinion or they need to switch outright, to make a permanent switch to another doc, I like that they ask me because I know who the other specialists in our region are, and so I can direct them to somebody that I know is competent and will give them good care. So, but it is possible for the doctor to initiate that.
And I suppose, as you were saying, in your clinic, everyone, doesn't think with the same mind, but you sort of have an ethos that as you're working together, and someone might be equally as competent as you or Dr. Tuohy as yourself, but maybe see things a different way than you. And would that be someone who you would think of, if someone says, "Oh, I want to focus more on this wedge of the MS pie," and you're able to say, Actually, I know Doctor, himself or herself over at this clinic. That's maybe who you should think about seeing, and then talk to the nurse practitioner about it. Is that how that would work a little bit?
Yeah, a good example here in Seattle. Seattle, I'm sure the audience knows, is a pretty liberal place, and we have a lot of alternative healthcare providers, and it's reasonably common in this part of the country that patients will want to go to a naturopath and get naturopathic treatment, which doesn't align with Western treatment that well. But when they bring that up, I like it if they're leaning that way and they bring it up to me, because there are two naturopaths in the region that work very well with us as traditional doctors. In fact, they have both rotated through every MS center in our region to see how we do it. So I can send people to the person that I know is going to do the naturopath treatments with them, but will also emphasize that, oh, you need to be on your MS drugs, and you need to keep seeing your regular traditional doctor as well. So yeah, if they have treatment goals and objectives that don't align with ours, if we can discuss that with them, we can usually get them to another provider that does partner with us well, at least.
Okay, no, that's very good. And Ciara, as a nurse, as a teacher of nurses, and we've touched on the MS nurse a few times here, and as a person living with MS, as a nurse living with MS, tell us how you feel that the nurses come into play, not just in general. First, in general, when it comes to MS treatment, but then when it comes to the maybe some difficulties with the neurologist patient relationship. And I use that. Most people will think it odd that I use the term patient tonight, because typically I use person living with MS, because I feel for me myself personally that I'm only a patient in that 20 minutes, half an hour that I'm actually in the surgery, that I'm in the exam room with my professional. The rest of the time, I'm just a person who happens to have the disease. But we're talking now. We're in surgery. We're in the office, the clinic, whatever you want to call it. So we are patients at this point. So how does the nurse come into the patient-doctor relationship, Ciara?
Yeah, so I think Travis, maybe I'll be a bit biased in this, but I think their role is so integral because the nurse is often the front-facing person that we see in clinic. Or I know for myself, my own experience, I only see the consultant when there's something wrong. So if there's something new on a scan or there's just something not good, you see the consultant. It's the MS nurse specialist that I will see on a regular basis and be in contact with before an infusion clinic and go through things with her. And she's the one that checks in. And she's so integral because over the years, I've been fortunate, it's been the same MS nurse since I've been diagnosed. So we've built up a rapport that I feel comfortable going to her about things. And if I wanted to change neurologist, I would feel comfortable to go to her because I feel that she could advise me and guide me. And nearly as well, I think it takes that, as James and Orla had mentioned, sometimes as a patient, you feel I'd be too embarrassed to say to you, I want to change consultants. The MS nurse is that nice buffer. Will you tell him or her that I'm thinking about changing consultant? And it's just that nice buffer, that nice rapport, and I think as well they're integral for my own experience. That MS nurse is integral between that patient consultant relationship as well, because oftentimes the patient is relaying their concerns to the nurse, who then is taken to the consultant and will come back to you then at a phone call to say, I discussed it with Dr. X or Y, and this is what they think. So it really is, I think, a fundamental aspect of it. And it's great to have that extra layer to it, that it's not just with the consultant, but that you have that extra relationship with the MS nurse that's there as well.
No, that's brilliant, and I've always felt like the MS nurse was the first call if there was an issue, or the first email. Now that emails can be protected far enough, etc. And I guess I had the same perception that many people have, particularly here in Ireland, because of the way that the public health system works, etc., that things were exceptionally rigid. And part of that is because of the timing structure that we have with our doctors. You've got 10 or 15 minutes and that's it. And it's a hard in, it's a hard out. But I had a recent experience that was part of the reason that I wanted to have this conversation. It had nothing to do with MS. We have a dear friend who is, we'll just say, in an oncology situation right now that's not good. And we were under the impression that things were going to go a certain way, and that was the only way they were going to go, and that was it, unfortunately. And then all of a sudden we got a letter requesting a consultation, an MRI, and a consultation with a surgeon in Cork at the University Hospital, actually at Mercy. And I was very confused, and so I got in touch with the oncologist we've been working with and said, I thought that this was, surgery was out of the question. This was inoperable. This was, palliative, etc. And they said, well, we just wanted to make sure. So we're sending to a colleague in another county, in another hospital, etc. And I thought to myself, and Professor Bowen and I have had this conversation about neurologists are they were the presidents of the chess club, and surgeons were the captain of the football team. But the concept that a doctor, a multidisciplinary team would say, yeah, actually, you know what? We're not the ones. We want to just double check ourselves here and send someone, and we got the answers the same. But I was really struck as a person who had preconceptions, I suppose, about the Irish medical system, that the team just put egos aside and said, this is what's best for the patient, or we hope it's better for the patient. So that, again, as well as hearing that this is possible, that was one of the reasons that I wanted to do this program, is because really the doctors do have our best our best selves and our best outcomes in mind, even if it isn't with their team. So that was pretty impressive and pretty profound for me. And Dr. Tuohy, would you say that that is a misconception about the Irish healthcare system, that it is that rigid?
Yeah, I suppose I suppose we're all time poor, aren't we? And often that sort of consultation that you have is maybe that 15 minutes, but I suppose there's a process around that then as well that that involves, after the consultation, us typing up our, dictating the clinic letter and then editing it. And often as part of that, then going through people's maybe blood test results and scans and having another think about their case, for example, and to kind of planning all around that then as well. So some of that work that I suppose maybe goes on behind the scenes a little bit as well. And as well, I suppose part of that MDT working as well, if there are particularly challenging cases, for example, from a diagnostic point of view, or from a treatment point of view as well, there are, harnessing modern technology nowadays to do MDTs and to where you can get kind of the best minds in the country kind of coming together to work through and to think about what the best management options for people are as well. Yeah.
And MDT, for those who don't know, that's multidisciplinary team. So
Yeah,
that would
sorry.
be that. No, that's fine. That's why we do these things. So for a lot of people who I'd say I'm a recovering chef. I'm retired from the business because of MS, but so many people see that 2 or 3 hours of dinner service, and they think, wow, the chefs have it pretty easy, just 2 or 3 really hard hours. They don't see the preparation time, the setup time, the cleanup time afterwards. So you're saying that that 15, 20 minutes that we might 10, 15, maybe even minutes that we get with you, triple that for the reading of the notes beforehand and refamiliarizing yourself with the case, having the actual clinical time to do an exam and have the time, and then all of the follow-up afterwards. We're talking, if we get 10 minutes with you, you're at least 30 minutes on our case.
Yeah, and then I suppose the other thing that should be happening as well is that people with MS should be seeing their MS nurse as well, for example, for that holistic around care. For example, if for example, with your appointment with the neurologist, you've discussed your treatment and any side effects from it, and any issues that you have to raise, then maybe you speak to your MS nurse then about other topics we haven't covered, day-to-day life, or any other concerns or things that you might have, or issues that might be active for you at the moment. And as I said, sometimes it might be that you're more comfortable talking to the nurse about certain topics, for example, due to, family planning and things like that as well. I suppose in women is a big one as well. So that all round, that it's not just that, that 10, 15 minute time slot that you have, that there's a whole, other time frame around that as well.
Right. And Professor, I remember when I would come and see you, one of the things that we got in the paperwork beforehand had a list where it was, what 3 things do you want to talk about with the doctor today? What kind of preparation should we as patients going in to see our doctors come to, so that limited time, and it doesn't matter if it's in Ireland or Scotland or the US or Tahiti, it's always going to be limited time that we get. I suppose it'd be nicer Tahiti in the waiting room. But what can we do to prepare so that even if a relationship is a little bit strained, or it's not what we consider ideal, that you get the most from us and we get the most from you? What things can we do?
Yeah, I think the most important thing is to organize your thoughts as a patient. And you may remember in our clinic, it wasn't always put the 3 things that you want to discuss. It used to be open-ended, and people would go on for like 12, 15, sometimes 2 pages of things. And there's no way you can do that. So that's why we changed it to tell us the 3 things you want to discuss. And that's about all that you can get done. Our appointments are unusual in our clinic. In the States, a typical neurology visit is 15 minutes, but ours are 30 for a return patient. And honestly, it's hard to do 3 things in 30 minutes. So, but if you can organize it and have them prioritized, because you may not even get all 3 answered, and you may need another 30-minute slot on a different day to get to all of them, it would be really helpful. And then also to bring the necessary information with you. If you're bringing an outside imaging, make sure we have it ahead of time. That it takes a day or so to load it into our computer system so that we can see it easily. I have a lot of patients that would bring, they see uh, things on the internet about, supplements and things that would cure whatever disease that they're concerned about. And it'd be nice to bring us that information because the name of the supplement tells us nothing. We want to see the ingredients in it. So, but yeah, just prepare, and that way we can use the time efficiently.
So it's not Dr. House where you just throw up the thing, the X-ray on the backlight and say, "Oh, I see where the problem is here. Now we can cure it."
That's right. Maybe the Irish doctors put it up on the view box, but we would hold it up to the window because we don't have view
Yeah,
boxes.
because in Seattle, you get diffused light all the time.
Yes, but yeah, they're all online on the computer. So you have to download it from your disk, your CD, onto our computer system. The download only takes a minute, but it takes a day or so for that to be integrated into your chart and through that computer system. And then, of course, most computers don't have CD drives anymore. So, but the radiology computers do.
This conversation brings me back to the smell of double mint gum and stale cigarettes and rubbing alcohol in my childhood GP's office. Whenever I would come in with a complaint, he told me that the most important thing was this, and he took my hand and he would fold my fingers to this. He said, "Now take that and point to where it hurts." So there's a neurological version of that. Is all right. Tell me what point exactly where, not here. This is what I want to talk about today.
Right. Yeah.
Geez, there's so many more questions I want to ask. But our time is kind of going along here, and I wasn't joking. There's an awful lot of people who want to watch the semifinals of the Eurovision Song Contest tonight. We've covered a lot, but there's a lot more that begs a discussion. These hours always do come to an end very quickly. So I'm going to ask all of you for some final thoughts on. And I'm going to go in the order of Dr. Tuohy, Professor Bowen, and then you, Ciara, because I'm going to give you a little time here. So when it comes to these difficult topics, what are your final thoughts, Dr. Tuohy, on finding a new doc or making the best of a less than optimal situation?
Yeah, so I suppose just the importance of communication, I suppose, good and effective communication. And I guess we don't always get it right. We don't always gel with someone. So not being afraid to kind of to voice those concerns, I suppose. We're all human at the end of the day, and we all understand, I think. And as James said, we all do have a thick skin in terms of and we all, I suppose, at the end of the day want the best for patients and want them to feel comfortable with their neurologist and their care.
And Professor Bowen, final thoughts from you?
Yeah, I would agree. It's good to get a neurologist that you get along well with, but keep in mind that the neurologist is there to be your doctor, not your friend. Sometimes it does end up being your friend, and I really enjoy that. But really, you want information from the neurologist that's accurate. The other thing I would add is that um, when you think about MS issues that you need a doctor for, one is long-term treatment of the MS. That's where the neurologist comes in. But the other is how are you going to get treated for an acute MS attack, which would generally involve two things: steroids, and also evaluating you to make sure that it's not a pseudo attack with something like an infection. So you really need a GP that you can work with in your local neighborhood that you can get in quickly with to make sure you don't have a bladder infection or something that's triggering this. And those two, the GP and the neurologist, actually need to work together. So you need two people on your team at least.
Very good. And Ciara, final thoughts from you on the concept? Maybe not as a nurse, but as a person with MS.
Yeah, so I think, and hitting off what Orla and James have said as well, I think communication is so key, Travis, that sometimes we think we don't have a great relationship with a consultant because we might come away and say, why did he put me on this drug? Why did she tell me to do this? And I always say, go into your appointment as a curious 5-year-old, but why? And ask, but why? But why are you putting me on this? But why are you asking me to do these exercises? And it's that integral communication, because if we speak and ask and understand, then maybe it helps with that relationship. Okay, now I can see why they want me to do this. And don't be afraid to go into the appointment with your notebook and pen. I know for me in the early stages, I was stubborn and I'm not bringing it in because I don't want them to see that I need to have a notebook and pen with me as a reminder. I know what I want to ask. Cognitive issues, cogfog, they're a part of everything of this journey, unfortunately. So don't be afraid to go in with your notepad, your pen, and that 5-year-old, but why, but why, but why?
And that you're not even throwing in everyone else's lab coat amnesia in there as well, that you forget about 80% of what's said in the consultation room. Listen, as it always does, our time has come quickly to an end. There's so much more to discuss on this topic, but my MS fatigue and this heat and all, we have to know when to say when. I thank our guests, Dr. Orla Tuohy, Professor James Bowen, and Nurse Lecturer Ciara O'Meara. You've been most generous with your time and helpful with your knowledge. I would be happy to be in the care of all of you, and I have been in the case of Dr. Bowen. As I said at the beginning of the program, we're going to take a break for the summer, give everyone a chance to not think about the unspeakables, and we'll be back on Thursday, the 18th of September, when we'll talk about comorbidities and co-occurring conditions that often accompany multiple sclerosis. We're calling that program MS and we hope you can join us. Until then, I'm Travis L. Gleason, wishing you and your family the best of health and a lovely summer. Cheers. Back to you, Fergal.
So I'd like to thank all the guests again, Orla, Ciara, and James, for a wonderful talk. And again, as usual, Travis, for being such a great host and for being such a great host over the last few months. And just to let people know that we have another webinar coming up for World MS Day. It's not an Unspeakable Bits, but it's an MS Ireland one, and myself and Travis are going to be doing that as well. And that's the 29th. It's for World MS Day. It's the day before evening time on the 29th of May. And I put up a link, but the link is also on all our socials. And also to let people know that this is recorded, and as usual, I'll put it up on our YouTube channel with all the previous episodes, and I encourage people to go back to those if they haven't already. So again, thank you so much, everyone, for a wonderful talk. Take care. Enjoy the rest of the evening.
Cheers.